skull. Anteriorly, scalp extends up to superciliary arch, while posteriorly it extends up to the external occipital protuberance, and from there laterally to the superior knuckle line. Okay, so anterior limit is superciliary arch, posterior limit is up to external occipital protuberance and superior knuckle line, and laterally the scalp or thin sheet of scalp extend even up to the zygomatic arch. So the superficial part of the temporal region is also included within the scalp. Okay, which will be more clear from this diagram. So right from the superciliary arch anteriorly, scalp extend back up to the external occipital protuberance, and from there laterally to the superior knuckle line. Okay, this is the anterior posterior extent of the scalp. While lateral extent of scalp extend up to the zygomatic arch. Okay, so the superficial part of the temporal region is also included within the scalp. This is about the extent of the scalp, which is the soft tissue that covers the cavity of the scalp. And the scalp consists of 5 different layers. Okay, scalp consists of 5 layers. These 5 layers of scalp can be memorized by using a mnemonics, which initials represent the word letters. The word scalp itself. SCALP scalp itself denotes the 5 layers of the scalp. So the S, which stands for outermost layer, that is skin. Okay, next to the skin, C stands for dense connective tissue, A for aponeurosis, which is also known as ilia aponeurotica, L for loose areolar tissue or loose connective tissue, and P, finally, the innermost layer or 5th layer is P, which stands for pericranium or periosteum. Okay, so the first layer of scalp is skin. Second layer is dense connective tissue. Third layer is aponeurosis, which is the aponeurosis that connect the epicranius muscle. Then the fourth layer is loose areolar tissue, and the 5th layer is the pericranium, which actually is the periosteum itself, which covers the outer table of the bones of scalp. Okay, so these are the 5 different layers of scalp. Just to recall: skin, dense connective tissue, aponeurosis, loose areolar tissue, and pericranium or periosteum are the 5 layers of scalp, which can be memorized by the mnemonic later or the word scalp itself. Okay. So the first or the outermost layer of scalp is skin, and the skin of scalp here is the skin is thick type of skin here. Okay, the skin of scalp is thick, hairy, rich in very much numerous sebaceous glands are present there along with the sweat gland, and it has high vascular supply. Okay, so thick skin, hairy, rich in sebaceous and sweat gland, and rich blood supply. These are the characteristic features of the skin of scalp. And because of this numerous numbers of sebaceous glands present within the scalp, scalp is one of the site of or the common site of formation of sebaceous cyst. Okay, because of numerous sebaceous glands present within the skin of the scalp becomes one of the common site for formation of sebaceous cyst. Then next or the second layer is connective tissue, and the connective tissue or the second layer of the connective tissue in scalp is dense connective type. Okay, so this dense connective tissue which is composed of highly organized or highly dense fibrous connective tissue which contain large amount of blood vessels and nerves. Okay, and remember, as this dense connective tissue has or the arrangement is highly fibrous network are present. So in case of open wound, like any or even small minor injury occurs in the scalp that results in opening up of the blood vessels present within the scalp, it results in profuse bleeding. This is because the blood vessels of the scalp present in second layer is embedded within the connective tissue layer. Because of this attachment of wall of the blood vessel within the connective tissue, the wall of the blood vessel doesn't retract if it is open up in case of open wound, if it opens or torn in case of open wound. Okay, so because of as the blood vessel can't retract back by itself because of attachment within the connective tissue, the wound in case of scalp, the even the minor open or minor wound will bleed profusely. Okay, so there is chances of profuse bleeding in case of injury to the scalp. Then the third layer is epicranius along with its aponeurosis. So the third layer include epicranius muscle and its aponeurosis, and this epicranius muscle include two pair of muscle. The anterior muscle is known as frontal belly. Okay, and the posterior belly is known as occipital belly, and in combination, both of these muscle is considered as occipitofrontalis muscle. Okay, occipitofrontalis muscle, which is considered as the epicranius muscle, or actually this forms the third layer of the scalp and the galea aponeurotica, or the aponeurosis of this frontal belly and occipital belly. Okay, so frontal belly of occipitofrontalis and occipital belly of occipitofrontalis forms the epicranius muscle. And as we can see in this diagram, the occipital belly is present at the posterior aspect of the skull. Okay, talking about the origin of this muscle, this occipital belly arises from the lateral two-third of superior knuckle line. Okay, lateral two-third of superior knuckle line of the occipital bone, and also from the adjacent mastoid bone. So from the mastoid bone and from the occipital bone, this occipital belly arises and is inserted within the galea aponeurotica, or the epicranial aponeurosis. While the frontal belly arises from the frontal belly doesn't has any bony attachment. Remember this thing. Okay, frontal belly doesn't has any bony attachment, so it simply arises from the skin and subcutaneous tissue present beneath the eyebrow and root of the nose. Okay, remember the occipital belly, or I mean frontal belly of occipitofrontalis arises from the skin and subcutaneous tissue present over the eyebrow and root of the nose. Okay, then the muscle fibers move upward and is inserted within the galea aponeurotica at the level of coronal suture. Okay, at the level of coronal suture, this frontal belly of occipitofrontalis is inserted within the galea aponeurotica. So, and thus the tabulated form of this origin insertion of this frontalis and occipitalis. This frontal belly arises from skin and subcutaneous tissue of eyebrow and root of the nose, okay, and is inserted within the galea aponeurotica at the level of coronal suture, while occipitalis arises from lateral two-third of superior knuckle line and adjacent mastoid bone of the temporal bone, and the superior knuckle line actually is the occipital from the occipital bone. Okay, and is inserted here also is inserted within the galea aponeurotica. While talking about the nerve supply, this frontal belly of occipitofrontalis is supplied by temporal branch of facial nerve, while the occipital belly is supplied by posterior auricular branch of facial nerve. Both of them are supplied by different branches of facial nerve. Okay, the anterior one is supplied by temporal branch of facial nerve, and the posterior one is supplied by posterior auricular branch of facial nerve. Talking about the action of this epicranius muscle, the frontalis when contract cause the eyebrow to raise up, like when we have some surprised, when we have the surprise expression within the face. So this frontalis help in raising the eyebrow, and when this frontalis and occipitalis muscle contract simultaneously, it causes the scalp to move forward and back. Okay, so these are the movement of the muscle along with its origin, insertion, and nerve supply. So this is just to show this epicranius muscle, which is occipitofrontalis. This is occipitalis or occipital belly of occipitofrontalis, and this is frontal belly of occipitofrontalis. And remember, this frontal belly has no any bony attachment. It arises from the skin and subcutaneous tissue over the eyebrow and the root of the nose, and is inserted within the galea aponeurotica. Here, it arises from the lateral two-third of superior knuckle line of occipital bone, and also the adjacent part of the mastoid bone. The muscle fiber rises upward and is inserted within galea aponeurotica. So this aponeurosis between the frontal and occipital belly is the epicranial aponeurosis or galea aponeurotica. Okay. And remember, this first three layer of scalp. What are the? Can you recall 5 layers of scalp? Anybody? Just speak out. What are the 5 layers of scalp? What are the 5 layers of scalp? Are people there?
Skin,
Skin.
connective tissue,
Okay, connective tissue,
aponeurosis,
aponeurosis,
loose areolar tissue,
loose areolar tissue, and then finally
peritoneum.
or periosteum. Okay, so among these 5 layers, the first 3 layer, which includes skin, connective tissue, dense connective tissue, and then this epicranius or the Galea aponeurotica. These three layers of scalp act as a surgical layer. First three layers act as a single unit, okay, as they are firmly adherent with each other and they move like a single unit. So they are considered as a surgical layer of scalp or scalp proper. Okay, so here we can see this epicranius muscle, frontal belly of occipital frontalis, and then occipital belly of occipital frontalis. And remember, sometimes this temporoparaetalis, can you see here, is also sometimes labeled as the epicranius muscle, temporoparaetalis muscle. So, what is this temporoparaetalis muscle? Let's see. Mainly, occipitofrontalis is the epicranius muscle, okay, and sometimes this temporoparaetalis may also be present in some individuals. Actually, these muscles are just vestigial muscles, okay. So it may be absent in individuals, and if present in individuals, they are this muscle is also considered as epicranius muscle, which is temporoparaetalis. Okay, so this temporoparaetalis muscle arises from Galea aponeurotica, okay, below the frontal belly, and is inserted within the root of the auricle between this superior auricularis and anterior auricularis. Okay, so anterior auricular muscle and superior auricular muscle in between this temporoparaetalis is present, which arises from the or which origin from Galea aponeurotica and is inserted at the root of the auricle. Okay, so remember this auricularis muscles, superior, anterior, and posterior auricularis muscles are the muscles which help in movement of the pinna. If you have seen or you have heard about, like some people can move this auricle. Have you ever seen that? Some people can move this auricle upward, forward, backward because of this auricularis muscle. Okay, superior auricularis pulls the muscle upward, anterior auricularis pulls the muscle forward, and posterior auricularis pulls the auricle backward. Okay, actually, these muscles are vestigial muscles, and in some individual, these muscles are still active and they can move their auricle, but most of the people cannot do that. Then let's talk some detail about the Galea aponeurotica. As we have seen here, this Galea aponeurotica is the aponeurosis which connect the frontal belly and occipital belly of occipitofrontalis muscle. Okay, or it intervenes between the frontal and occipital belly of occipitofrontalis. And when we talk about the extent of Galea aponeurotica, so Galea aponeurotica extend anteriorly in between two frontal bellies to get attached at the subcutaneous tissue of a root of nose. Okay, while this Galea aponeurotica extend backward between two occipital bellies to reach up to the external occipital protuberance. And the same Galea aponeurotica laterally extend as a thin sheet of membrane to get attached to the zygomatic arch. Okay, this is the extent of Galea aponeurotica. Anteriorly, it extends between two frontal bellies to get attached at the subcutaneous tissue at the root of nose. Posteriorly, it extends between two occipital bellies to get attached at the external occipital protuberance, and laterally, it extends as a thin sheet of membrane to get attached at the zygomatic arch. So these are the extent of Galea aponeurotica. Okay. Then the fourth layer of scalp is the loose areolar tissue. Okay, fourth layer is the loose areolar tissue, and this loose areolar tissue is actually a potential space that contains emissary vein. Okay, as it contains this loose areolar tissue, it is considered as a potential space. It is very narrow space, and this fourth layer consists of emissary vein. See here, this emissary vein which actually connect the vein of the scalp with the internal venous veins, like these dual venous sinuses. Okay, the scalp vein is connected with the dual venous sinuses with the help of emissary vein. So as this emissary vein is present mainly within the fourth layer of scalp, so if in case of any infection, suppose any infection occurs or any sebaceous cyst or any type of infection occurs within different layers of scalp, the infection may directly into the dural venous sinus through this emissary vein. As these emissary veins are valveless, so the infection spreading of infection may be vice versa, from internal to external or from external to internal. Okay, so this fourth layer of scalp is considered as dangerous area of scalp because it can help in easy spread of infection from one part to other part of the from outside to inner aspect of the skull. Then the fifth layer is pericranium, which actually is the periosteum on outer surface of calvaria. Okay, so this pericranium is the fifth layer or the innermost layer of the skull, and this pericranium may be continuous with the endocranium through this sutural ligament. This sutural ligament is present within the suture. Okay, so the sutural ligament helps in connecting the periosteum with the endosteum in case of skull. Then let's go for the arterial supply of scalp. So scalp is supplied by five different sets of artery. Okay, scalp is supplied by five sets of artery on each half. So among these five arteries, three arteries lies in front of the auricle and two arteries lies behind the auricle. So let's see what are the five sets of arteries that supply the scalp. Firstly, here just at the supraorbital margin, from supraorbital margin, the first artery here is supratrochlear artery. Then next to that, supraorbital artery. So these supratrochlear and supraorbital arteries are the branches of indirect branches of internal carotid artery. Okay, so supratrochlear, supraorbital are the two arteries. Then the third arteries that lies in front of auricle is superficial temporal artery. Okay, so this superficial temporal artery, which is the branch of one of the terminal branch of external carotid artery, even we can feel the pulsation of the superficial temporal artery. If we place our fingertip just in front of the auricle or at the preauricular point, we can feel the pulsation. Try it, you can feel it. We can feel the pulsation of the superficial temporal artery just in front of the auricle, that is preauricular point. So the superficial temporal artery is the branch of external carotid artery, terminal branch of external carotid artery. Then two arteries that lies behind the auricle is this posterior auricular artery, okay, and then occipital artery, which are also the branch of external carotid artery. So among these five sets of arteries supplying the each half of scalp, supratrochlear and supraorbital are branches of internal carotid artery, superficial temporal, posterior auricular, and occipital artery are the branches of external carotid artery. So this makes like the scalp is now the site or area of anastomosis between internal and external carotid artery. Okay, finally, this internal external carotid artery anastomose with each other within the scalp. So this is about the arterial supply. Once again, to repeat, the arteries of scalp are supratrochlear from anterior to posteriorly, supratrochlear artery, supraorbital artery, superficial temporal artery, posterior auricular artery, and occipital artery. Okay. And then talking about the venous drainage of scalp, scalp is or the veins of the scalp correspond with the artery. They accompany the corresponding artery. So each half of the scalp is also drained by five different vein drains or five set of vein drains each half of the scalp. Okay, so what are these veins and how they finally terminate are the first vein is supratrochlear vein, which accompany the supratrochlear artery. Okay, supratrochlear vein. Supraorbital vein, which accompany the supraorbital artery. The supratrochlear vein and supraorbital vein unite with each other at the medial angle of eye. Okay, as we can see in this diagram, the supratrochlear vein and supraorbital vein unite with each other to at the medial angle of eye to form the angular vein. Okay, angular vein. And then this angular vein continues down, runs obliquely through the face to form the facial vein. Okay, clear? So supratrochlear and supraorbital vein unite to form the angular vein at medial angle of eye. The next vein, which accompany the superficial temporal artery, is superficial temporal vein. You can see here in this diagram clearly the superficial temporal vein, which accompany the superficial temporal artery, okay, unite with maxillary vein. See here, superficial temporal vein unite with maxillary vein to form the retromandibular vein. Okay, let's trace this one once again. Superficial temporal vein unite with maxillary vein to form the retromandibular vein. And this retromandibular vein runs through the parotid gland. Okay, parotid gland. It runs through the parotid gland, and within the parotid gland, retromandibular vein further divides into anterior division of retromandibular vein and posterior division of retromandibular vein. Okay, so then see here, anterior division of retromandibular vein unite with the facial vein to form the common facial vein, and this common facial vein finally drains into the internal jugular vein. Okay, are you people getting my point? Are you people there?
Yes, ma'am.
Okay. And then the fourth set of artery is posterior auricular artery, which is accompanied by posterior auricular vein. Okay, posterior auricular vein accompanying posterior auricular artery. Now, this posterior auricular vein unite with the posterior division of retromandibular vein. See here, posterior auricular vein unite with posterior division of retromandibular vein to form the external jugular vein. Okay, so are people clear about this? Once again, supratrochlear vein and supraorbital vein unite to form the angular vein at the medial angle of eye. So the same angular vein receives numbers of other tributaries and runs obliquely through the face to form the facial vein. Okay, now this facial vein unite with the anterior division of retromandibular vein to form the common facial vein, which finally drains into intrajugular vein. While in turn, this anterior division of retromandibular vein actually it is formed by union of superficial temporal vein with maxillary vein to form the retromandibular vein. Retromandibular vein further divides into anterior division and posterior division. Anterior division unite with facial vein to form common facial vein. Posterior division of retromandibular vein unite with posterior auricular vein to form the external jugular vein, which drains into the soft clavin vein. Okay, so which one is the remaining vein now? There should be five sets of artery drains the each half of scalp, isn't it? Which is accompanied by five different arteries. So five different vein. So here we have talked about four vein. What is the remaining vein now? Do you remember five set of arteries? Supratrochlear artery, supraorbital artery, superficial temporal artery, posterior auricular artery, and which one? What is the remaining of fifth artery? That's occipital artery. Okay, so finally, the occipital vein is there, which accompany the occipital artery, and this occipital vein drains by draining into suboccipital venous plexus. Okay, occipital vein drains into suboccipital venous plexus that lies beneath within this occipital granule. Okay, and this occipital venous plexus finally drains into the brachiocephalic vein. Okay, so see here in this diagram also, this is the internal jugular vein and this is the external jugular vein. External jugular vein, which is formed by union of posterior auricular vein with the posterior division of retromandibular vein to form the external jugular vein. External jugular vein drains into the subclavian vein, and we know subclavian vein and internal jugular vein unite to form the brachiocephalic vein. Right and left brachiocephalic vein unite to form the suburvenic cava, and from there into the right atrium of the heart, how the vein drain finally into the right atrium of the heart. Okay, so I hope people are clear about this arterial supply and venous drainage of the scalp. Then let's go for the nerve supply of scalp. Okay, so unlike artery and vein, there are five sets of arteries and five sets of vein accompany the corresponding arteries. Okay, but in case of nerve, talking about the nerve supply of scalp, in total of 10 different nerve supply each half of the scalp. Okay? Each half of the scalp is innervated by 10 different nerve. So in this those 10 different nerve, again let's start from before backward. First one being supratrochlear nerve. So here also the supratrochlear, supraorbital nerve and arteries, they are the same name. Okay, supratrochlear nerve, which is the branch of ophthalmic division of trigeminal nerve. Supraorbital nerve, this is also the branch of ophthalmic division of trigeminal nerve. Okay, zygomaticotemporal nerve, which is the branch of maxillary division of trigeminal nerve, and auriculotemporal nerve, which is the branch of mandibular division of trigeminal nerve. Okay, so this ophthalmic division, maxillary division, and mandibular division of trigeminal nerve. These four nerve are sensory nerve that lies in front of the auricle. Like in case of arterial supply, in front of auricle there are three sets of artery, and behind the auricle there are two sets of artery. But here in case of nerve supply, there are in total of 10 nerve. Okay, so five nerve lies in front of the auricle and five nerve lies behind the auricle, and each five nerves before behind and in front of this auricle has four sensory nerve and only one motor nerve. Okay, so here five nerve in front of auricle, all of these four are sensory nerve, and this temporal branch of facial nerve is the only motor nerve. Similarly, on the posterior aspect of the scalp, Here also, this greater auricular nerve, which is from the cervical plexus, lesser occipital nerve from the cervical plexus, greater occipital nerve, third occipital nerve, these are all derived from the cervical plexus, and the single motor nerve is posterior auricular nerve, which is also the branch of facial nerve. Okay, so posterior auricular branch of facial nerve is the only motor nerve, and here also temporal branch of facial nerve is the only motor nerve that lies in front of auricle and behind the auricle. The rest of all are the sensory nerve. Okay, so I think it will be more clear from this flow diagram also. Nerve supply of the scalp, there are in total 10 nerves, 5 in front of the auricle, 5 behind the auricle, 5 in front of auricle. Among these 5 in front of auricle, 4 are sensory and 1 motor. So this all 4 sensory are from the trigeminal nerve. Okay, first one being supratrochlear and supraorbital nerve, branch of ophthalmic division of trigeminal nerve, zygomaticotemporal nerve, branch of maxillary division of trigeminal nerve, auriculotemporal nerve, branch of mandibular division of trigeminal nerve, while the only motor nerve is temporal branch of facial nerve. Then also behind the auricle, there are 5 sets of nerve, among which 4 are sensory and 1 motor. The only motor nerve is posterior auricular branch of facial nerve, while the sensory branches are all the branch from cervical plexus. Okay. So greater auricular nerve, lesser occipital nerve, greater occipital nerve, and third occipital nerve. All of these are the sensory nerve branches from the cervical plexus. So as we have seen from this diagram also, this trigeminal nerve and cervical nerve has a considerable overlap. Dermatons of this trigeminal nerve and dermatons of this cervical nerve has considerable overlap. Okay, so because of this reason, and also as the scalp is composed mainly of dense connective tissue, so during any kind of surgery of the scalp, local anesthesia is not preferred because of dense tissue, the local anesthesia cannot diffuse readily. Plus, and because of this considerable overlap of the dermatum of this trigeminal as well as cervical nerve, so local anesthesia will not work properly in case of scalp. Okay, for that any surgery to scalp is suggested with general anesthesia. Okay, remember this thing. Then let's go for the lymphatic drainage. Okay, lymphatic drainage of scalp here. So this is about the face. So we are not concerned about face for now. So when we talk about the lymphatic drainage of scalp, the anterior part of the scalp drains mainly into the pre-auricular or superficial parotid lymph node. Okay, so anterior part of the scalp drains into pre-auricular or superficial parotid lymph node, while posterior part of the scalp drains into post-auricular or mastoid group of lymph node, and this post-auricular and mastoid group of lymph node also finally drains into the occipital lymph. Okay, remember anterior part of the lymphatic drainage drains into pre-auricular lymph node and posterior part drains into the occipital, finally into the occipital lymph node. So this is about the lymphatic drainage of scalp. And then let's go for some applied aspect related with the scalp. So as we have already mentioned, fourth layer of scalp is considered as the dangerous area of scalp or the dangerous layer of scalp. Okay, this is most oftenly asked in your MCQs. The dangerous layer of scalp is you have to find out first layer, second layer, third layer, fourth layer, or fifth layer. Okay, remember fourth layer is considered as dangerous area of scalp because as we have explained earlier also, this fourth layer consists of emissary vein, which connect these veins of the scalp with the dural venous sinuses. So, and this emissary vein, as they are valveless, so infection may spread to and from any part of the scalp. Okay, so this layer is considered as dangerous area of the scalp. Then, as it consists of the skin of the scalp consists of numerous sebaceous glands, so it is one of the scalp is one of the common site of sebaceous cyst formation. And one important condition like caput succedaneum is a condition where the scalp, a portion of the scalp of newborn is edematous. This occurs only because of the interferences in venous return. Like during the childbirth, the child head has to pass through a narrow birth canal. Okay, so while during parturition, when the child head passes through the birth canal, the because of compression through this birth canal, the venous return is interfered within the scalp. Okay, and because of this only, some portion of the scalp may be edematous, and this results this lasts only for a few hours to few days, and it recovers self. Okay, so this condition is known as caput succedaneum. So still there are many more clinical reference connected with this scalp, so you can go through your textbook, and this is all about scalp we have today. So any part, any confusion?